Thanks for joining us this evening. My name is Jason. I'm one of the cardiac surgery residents at Penn. This is a part of a TSRA series that we've been running for the past 6 months. It's sponsored by Atricure, and it's really about focusing on early career experiences. So thanks for being with us throughout this series. Tonight's event is going to be about early career advice in heart transplant and mechanical circulatory support. And we're excited to welcome two attendings that are going to be able to share a lot of advice about where they, what their story was and how they got into the field and what they think about it in terms of going forward. So I'd love to introduce our two panelists. Dr. Cervasco, do you want to kick us off in terms of, maybe you can mention where you trained and sort of the different paths that led you here?
Sure. So I'm Marisa Cervasco. I'm now at Penn as an assistant professor, and I did general surgery. Really, there was no I6 program when I started. There was, I think, one had just started in Stanford, and so I did general. I didn't even know I wanted to do cardiac, so I started off with general surgery, and then had met one of the cardiac surgeons at Brigham in Boston, and he convinced me to go into his lab. And so then I went into his lab and did cardiac surgery research and really liked it. And so then I stayed on at Brigham, did the 4-3 program there. And then I went to, when I was graduating Brigham, I was kind of deciding if I wanted to go take a job right away or if I wanted to get advanced training. And I thought about different options. And then by, a connection between Brigham and Columbia, I met some of the surgeons at Columbia who needed a fellow to do advanced training in heart transplant and mechanical support. And I thought they had such a great reputation at Columbia that I wanted to go there and take that opportunity. And so I spent 2 years at Columbia doing advanced training in all aspects of heart surgery, but with an additional focus on transplant and mechanical support. And so I spent 2 years there. That was the deal. So I had to, it wasn't a 1-year option. It was like, if you signed up, you had to do 2 years. So typically they had taken Japanese fellows from overseas. And so they were used to, having a commitment from them. And so I was kind of the first non-Japanese person they had taken. And that was totally fine that I signed up for 2 years. It was an outstanding 2 years.
Perfect. Thank you.
Yep.
Dr. Fiedler?
Hi, everyone. I'm Amy Fiedler. Thanks, Jason, and to TSRA for having us tonight. I'm really excited to participate. So similar to Marisa, I spent a lot of time in Boston. So I started off as a categorical general surgery resident at MGH. Also similar to Marisa, I had no idea I wanted to do cardiac when I was starting, and there wasn't even really the option of the I6 program when I entered residency. So my story is when I started at MGH, I actually thought I would do something like surgical oncology or pediatric surgery. But as PGY2s, we spent a lot of time in the cardiac surgery ICU. And I really enjoyed my time in the ICU. And then really what was pretty formative for me, specifically solidifying my interest not only in cardiac surgery, but also in heart transplant, was I'll never forget on my birthday, my second year of residency, there was a need for someone to go on a procurement with one of the attendings, and all the fellows were busy, of course, and I was naturally slotted to be on 24-hour call on my birthday. And so they're like, Amy, why don't you go on the procurement with the attending? And the attending was Jen Walker, who's now at UMass, but she had spent a long portion of her career at MGH. And we spent that whole flight all the way down to North Carolina doing the procurement and coming back with her talking to me about what it's like to be a cardiac surgeon, why I should definitely do cardiac surgery, stuff like that. And basically from that moment, I was sold. I also spent time in the lab at the Brigham with Marisa and Fred Chen's lab for 2 years doing heart failure research on sheep. And in a very similar fashion, I exited the lab and joined the 4-3 training program at MGH after that. And so in that program, for us, it's a little different than across town at the Brigham. Our training program was 2.5 years. And so that lent itself nicely to thinking about what you were interested in subspecializing in and having a dedicated time period at the end of your training to focus specifically on that. So I spent the last 6 months of my training really focused on mechanical circulatory support and heart transplant. And so when I was exiting training, I had a lot of kind of internal self-reflection as well as conversations with my mentors and such about, should I do some additional super fellow training, or would I be okay just kind of going out and entering the workforce, and ended up just going out and grabbing a job. So I'm currently an assistant professor of surgery at the University of Wisconsin here in Madison. My focus is on heart transplant, mechanical circulatory support. I've been here for about 2.5 years now, and I think one of the things that both Marisa and I can talk to you guys about tonight is the fact that we took a little bit of different paths in terms of getting to a similar place. And so there's pros and cons of both, and I think that's an important conversation. But my practice really does span the gamut from heart transplant, MCS, to just bread and butter adult cardiac surgery. And so again, thanks Jason for having us, and it's exciting to be with all of you to talk about the things that we're really passionate about and get you all interested in it as well.
Yeah, no, this is really great. So the conversations that we want to have this evening, I think you've addressed some of them already. Like, it's about the training pathways, the considerations that you have when choosing a field like heart transplant and mechanical circulatory support, and also what does your practice look like as you transition into that attending practice. But it seems like both of you guys worked at Fred Chen's lab. So maybe the first takeaway is that the key to success in a successful early career for heart transplant and mechanical circulatory support is Fred Chen. But the first question that I want to ask, because it came up organically in your story, is that as you were getting interested more and more in heart surgery, you were drawn to this field of heart transplant and mechanical circulatory support. Can you just speak broadly about what interested you about that field and why you thought that might be a great opportunity going forward? Maybe I can have Dr. Fiedler speak first.
Sure. For me, initially right off the bat, the thing that interested me about it was kind of the adrenaline surrounding it. I really like the transplants and the impact. I think cardiac surgery is a lot about making a huge impact on patients, but you really see that in transplant. And anyone who hasn't had the opportunity to participate in a heart transplant, I encourage you to do so, because it's really never loses the excitement when you take the clamp off and the heart starts beating in a transplant. And so that was, when I was very junior, what really interested me about the field. And then your interests kind of mature from there. And for me, one of the aspects that I truly enjoy about heart transplant and MCS in particular is the team aspect of it. There's a lot of aspects, or most aspects now, of adult cardiac surgery function around a heart team, which I think is incredibly important for patient care. But heart transplant and MCS and heart failure surgery is truly where this started. And it's a real multidisciplinary team, and the input of everyone on that team is incredibly important to not only choose the right patients for these therapies, but also to ensure that you have excellent outcomes afterwards. So the team aspect of it is something I really love. The other aspect of it that I love is the innovative aspect of it. So mechanical circulatory support has changed drastically even since I was a trainee. And we have new therapies, new options, and we now have machine-assisted perfusion, normothermic regional perfusion for transplant, DCD transplant. Things are just evolving really rapidly, and they're evolving in a different way than other aspects of adult cardiac surgery, which has focused more or less on kind of making access more, minimally invasive, stuff like that. That was never my interest, kind of smaller surgery, minimally invasive surgery. So this kind of just suits my needs and interests and intellectual curiosities.
Yeah, no, that makes a lot of sense. I mean, people always say that when you're in med school or if you're in a surgical residency, like, one thing that you have to see is a heart transplant operation, right? Like, you're paying med school tuition. They always give you the advice that that's one of the things that you may never get to see again. It's an incredible experience. So thanks for sharing that, Dr. Cervasco.
So I came about it kind of in a roundabout way. I had, again, like I had said, I wasn't really sure if I wanted to go and get a job right away, or if I actually loved congenital. I thought about doing congenital. I was interested in aortic. I actually looked at aortic fellowships. I looked at, a couple of different aortic fellowships. What brought me into general surgery was transplant. I wanted to do hepatobiliary transplant initially. And so I think I always loved transplant. And so when the opportunity arose to go do the advanced training, I just thought, well, this will be good. Plus, it was geographically worked for my family. So that was part of it. But, what Amy said as well, I love transplant. It's always gratifying. There's nothing better than a heart transplant. So there's that emotional aspect of it, I suppose. I also think, like Amy said, is I don't like doing, I like open surgery, and you'll never take away, big open surgery, at least probably not in our lifetime. Who knows, maybe I'll be wrong, but I don't imagine that we'll be doing minimally invasive heart surgery or heart surgery or heart transplants rather through a transcatheter approach. So, and I don't like wearing lead, but we have to wear it sometimes. But so I think those two things, and also the physiology of it. These patients are sick. You really actually have to be a doctor, especially when you're trying to get somebody from maybe ECMO to a VAD or ECMO to a transplant, or you meet all sorts of people in decompensated heart failure, and you have to figure out what the right way to bridge them. So it's just not as simple as sewing a couple circles together. Like, we can all sew the circles together. It's actually understanding the physiology and how to safely rescue a patient, keep their end organs intact, and get them to the next level of care in one piece, and doing well. And so I think there's an art to it. I think you have to be super diligent. You have to love patient care, and you do have to work with cardiologists, the heart failure team a lot, and it requires, I think, a detailed, meticulous approach. But ultimately, it is gratifying because you can really rescue sick patients. And for instance, I had a guy who came in, he was sick, known to the cardiology team. He, unfortunately, when we got called too late, when he was coding, we put him on ECMO. We woke him up and got him end organs intact. I put an axillary impella in him just to give him a little bit more time to recover. And then I bridged him to an LVAD. And that's kind of a nice thing. You really develop a bond with your patients, and you have to, be really diligent in terms of watching out for all these little things, and being a good doctor as well. So I think you're a good surgeon, but you also have to be a good clinician. And
yeah, I remember talking to you about that patient a few days ago too. So I'm glad to hear everything's going well. But the piece that really came across from both of your stories is that there's an aspect of understanding physiology, that you're not just fixing a simple plumbing problem, that you're actually trying to look at the continuum of care from somebody coming in extreme sickness, bridging them to different types of modalities, and then figuring out what the different pathways are. And I guess one of the questions that I had for you guys as a follow-up to that is, are there certain skill sets or practices that kind of bundle together very well in the field of heart surgery, heart failure and MCS? I see examples of surgeons who are doing, transplants in MCS and mitrals, or I see surgeons who are doing MCS, heart transplants and lung transplants. Is that something that you're sort of like guided down towards, or depends on mentorship and regional factors, or how did you approach that aspect of your practice?
I think it's go ahead, Marisa.
Oh, sorry. Yeah. I think it ends up with job you end up taking for the most part, a lot of the time. I mean, I never anticipated I'd be doing lung transplants, and now I'm doing lung transplants at Penn too, which is not a bad thing. It's just, it wasn't something that I, had envisioned. But a lot of places, the thoracic guys do the lung transplant, but at Penn, the cardiac surgeons do the lung transplants here. So I think that's one thing. I get a lot of the high risk CABGs that nobody wants to do, the low EF CABGs, or any patient with low EF, like, a very sick mitral patient. Penn is very compartmentalized. So people who need aortic surgery, they go to the aortic surgeons. And so, but when I looked at jobs, and I looked at a lot of jobs, and it really is a function of where you end up going. So, I mean, for me, I think it's useful to have, expertise in heart failure, because you get the patients who are super sick going into the operation or have low EF, and you need to know how you can, if you're going to be able to revascularize them effectively, and for instance, or if they'll tolerate the mitral replacement or repair, and how you can get them through, or how you need a temporary, support to get them through. But ultimately, I think maybe Dr. Fiedler can also speak to it, is, the particular job you end up taking.
Yeah, I think that's absolutely spot on. It's the job that you're taking. So if the job that you're taking is saying we want you to fill the role of the heart transplant, lung transplant, and MCS surgeon, that's the role that you're going to fill. And that's great if that's what you want to do, recognizing that you may miss some of the additional scope of adult cardiac surgery, and that's not so bad. For me, at the University of Wisconsin, we're a smaller practice. So we're 4 adult cardiac surgeons. And what that means is that my transplant partner and I do all the transplants and all the LVADs, but it also means that I have a pretty robust, broad based adult cardiac surgery practice as well. And similar to what Marisa is saying, I think that being a transplant surgeon lends itself nicely to the low EF cabbages, low EF mitrals, tricky redos that some people are less likely to take on because of the experience that we have as transplanters digging out 3-4 time redo LVAD, stuff like that. So some of those cases that other people are less have a less of an appetite for, a lot of times fall into our lap, and that runs the gamut of adult cardiac surgery. In my practice here, because we are not, we don't have, like a big aortic team or a big mitral team or whatever else, I'm lucky enough, especially as a junior faculty, to still have the opportunity to get a lot of those cases, which for me personally, I think has been very beneficial for my growth as a surgeon, because what that has meant was that I'm doing a huge chunk of our transplants and MCS volume, but simultaneously, I'm also doing a huge chunk of regular adult cardiac surgery. So especially as someone who did not spend 2 years like Marisa did doing a super fellowship where she was probably, I would imagine, effectively practicing somewhat autonomously at Columbia for a couple of years before taking a job, I've had the ability to really jump in the deep end as an adult cardiac surgery and have that adult cardiac surgeon and have that experience.
Yeah, I mean, it's actually really nice to hear that there's more variability. I think more and more as we speak to attendings, from a trainee's perspective, you always get kind of pigeonholed into these very simplified ways of looking at things, these heuristics that say, oh, if you're interested in this, then that's what your future is, and etc. So it's always nice to hear some real nuances in this situation.
Well,
And
Jason, and one thing I will say to spin off of that is that when you're looking at a job, one of the pieces of advice that I was given, which I do think is really solid advice, is really do some self-introspection about what you want to do. So for me, for example, I had no interest in doing lung transplant. I did a lot of lung transplant as a fellow, but I knew I did not want to do lung transplant when I came out as an attending. And I looked at a number of different positions, which I vocalized that I was not interested in doing lung transplant, but it was still kind of on the table, right? And be honest with yourself when you're looking at jobs. If it's going to be an opportunity where they're asking you to do something that you do not think aligns with your career objectives or is not something that you want to take on clinically, look someplace else or try to make sure that you figure out the position that's going to be best for you. Because I would say that the second that you walk into something that you are not doing the stuff you love to do and you're feeling burdened by it, that's probably not going to be an effective first job for you. So just think about it and don't just jump into the first job and say, I can do everything and I'll do everything and whatever comes to me, I'll do. Be a little bit thoughtful in your approach. I think that's important.
yeah, and it's perfect timing that you brought it up, because there's a question from one of the audience members, and I'm sort of going to take that and then put it into a larger question towards you guys. You said you've been through very extensive job searches. I'm sure that it spanned across many different types of centers with many different types of conditions. Overall, can you sort of describe what that process was like, and then comment on things such as what were these, employers' positions towards things like having an advanced training experience? What are they looking for you to fulfill in their practices, and what if there were any patterns that you came across that? And also, if you don't mind, I think a lot of trainees associate a practice in heart failure as an academic job because you handle all these very advanced technologies that you think are only at some centers that do high volumes of them. But is that actually the case? And have you come across private practice jobs that deal with these technologies? So can I go to you first, Dr. Cervasco?
Sure. Yeah, so I had some geographical constraints. My husband and I he wanted to live, really in New Jersey or as close to New Jersey as possible. And I actually took a job in private practice in New Jersey. I had signed the contract and then this opportunity at Penn came up, and it worked mostly with our geographical, constraint, and also it gave me the ability to do heart transplant, which I love. So I switched, but you have to have a certificate of need. So a lot of places, once if a place is telling you that they're going to start a heart transplant program, be wary. I think I heard that a couple of times when I was interviewing for jobs like this. It takes years, and it has to go through state legislature. It's just not going to necessarily happen. To answer the question, I guess, do you need to have a job to get a job at MCS and transplant without a super fellowship? I think it's certainly possible to do. It depends on the job market when you're graduating. I think that's one thing. And then it just depends on, how busy of a practice and what the place is looking for as well. Like if they're going to ask you to independently start doing VAD explant heart transplants, that go at 2 a.m. when you're by yourself right off the bat, then that might not be as realistic, because it has to be perfect. That's the thing. Like the transplants, it's so scrutinized. It's like cabbage operation. It has to be perfect. So, maybe you'd want an extra 6 months training. Like no one needs 2 years. But I mean,
just
I
you.
loved it.
Just you.
I love it. But so I think, just to answer your question, it depends on how broadly you're willing to search. Like I had a specific geographic constraint. So that was one thing that, really made me narrow my area of job search down. And then, I think it has to you have to get lucky too. And it depends on the market, the job market, and what's going on at the time. And, I don't know if you have any other suggestions for that. I think the takeaway is that, yes, you can get a job in that field without doing a super fellowship. Absolutely. It's just, you have to be aware of, understand how comfortable you are with potentially doing, some difficult cases. And if they're going to just set you out on your own, from the first case, or they're going to give you some guidance and mentorship for 3-6 months.
I think that that's absolutely correct. I would echo what Marisa says about really doing your due diligence about what the practice is going to provide you with respect to mentorship. Mentorship is incredibly important, I think, across all aspects of cardiothoracic surgery, specifically, I would say, in adult cardiac surgery and in congenital surgery. So understanding what the realistic clinical expectations of you coming out of your training program as an attending in the group are important. With your question, with respect to if it's feasible to get a job without doing a super fellowship, yes, you can. I didn't do a super fellowship and I got a job in transplant. With that, though, you have to be very intentional in your training. So I would say that if you're at an I-6 program that is not a robust transplant program, that might be more difficult because your numbers won't be as high. If you're at a place that does a lot of transplant, I would be very, very open and honest with your program director and the other individuals in your training program about your specific and dedicated interest in the field. And with that, make yourself marketable when you're coming out of training. What I mean by that is go on a bunch of procurements and become an independent procuring surgeon if your program doesn't make you do that already as a fellow. Do as many VAD explants, reoperative surgery, do as much as you can while you're a trainee. In doing that, you'll develop strong mentorship within your institution from the transplant surgeon or surgeons. And those people, it's a small community, right? I mean, Marisa and I have known each other for years from the Fred Chen Lab of Excellence, but now we're both at different institutions. We know a lot of different people, and it's a small community. And so your mentors know other people. They'll reach out and help you in terms of finding a job if they think that you're ready to stand on your own 2 feet after a super fellowship. But really, I think the most important thing is getting the most out of your training as you can, especially if you recognize that this is the niche that you're looking to explore coming out. And then Jason, I think you asked kind of a multi-pronged question about if it's only academics or if there's private practice in heart transplant and MCS. There most certainly is private practice in adult heart transplant and MCS. So you look at guys like Dr. Silvestri or Dr. Salerno, those guys work at institutions that don't have fellows, and they're really active transplanters, really active advanced heart failure surgeons. And they're really, they're on the podiums, they're giving talks, they're involved in webinars. So there are some smaller, not smaller places, but there are places across the country that are more not affiliated with major academic institutions that do heart transplant and mechanical circulatory support. If you take heart transplant out of it and you're interested in doing destination therapy LVADs, by all means, there's plenty of centers in a private practice model that are doing DT LVADs and referring bridge to transplants into academic centers with the transplant program. So some of that is about what you're interested in doing from a clinical standpoint, if you'd like to be engaged and involved with trainees and research as well.
Yeah, and actually, both of you gave very comprehensive answers, so thanks for that, to a multi-pronged question. One aspect that I wanted to dig in a little bit further about is, you mentioned first job considerations, and there were some aspects of, heart transplants and MCS that lends itself to a different way of looking at jobs than just, adult cardiac surgery broadly, I think. And one of the things that you mentioned, Dr. Cervasco, was the fact that the outcomes are strictly scrutinized. And I think as trainees, we observe that a lot too. We see that heart transplant outcomes essentially have to be perfect, and et cetera. So when you're looking for that first job and you're trying to set yourself up for success, and you mentioned a little bit about mentorship already, what are some other conditions that you should be looking for? Are you trying to aim for a certain amount of volume so that you get regularity in terms of getting established in your practice? Are you making sure that the donor calls are split up in a way where you might have somebody available to back you up at different times? How does that aspect work when you're looking for your job? I guess, Dr. Cervasco, we can go.
Sure. No, I can start. So I guess you're asking me what I look for in my job, in my first job. And I just want it to be busy. I mean, everybody wants to come out. We all go into surgery because we like to operate. So I just wanted cases. And so I put in my contract a guaranteed number of regular adult cardiac surgery cases. So that's what I said. I said I wanted 150 pump cases. Yeah. And I came out in coronavirus year. And I managed to, they managed to get me those 150 pump cases. And that's what I wanted. And then I did half of the heart transplants that went on at Penn. And then, I did lung transplant, and I never, ever thought I would have wanted to do lung transplant. And I have to say, it gave me a skill set, and I'm still learning it because I think it's actually harder than hearts. And it's not like I do it out of love. I do it because, it's a great thing to do for somebody, and it's challenging, but it gave me a different skill set. And, it's a marketable thing. That's the other thing. And it made me more comfortable around the pulmonary hilum and operating, and it gave me a different surgical skill set that I didn't anticipate having. And it does come at a price because, you do a double lung transplant and you're exhausted, and the next day you have 2 cabbages and you're can't even focus on the suture, but, because you're up all night. But that being said, for me, I wanted a certain case volume, and I didn't have much control over the donor call. People at, where I am now, they like to control the donor call themselves and just kind of farm out the transplants, which is totally fine. Donor call can be exhausting. At Columbia, the cardiologist took the donor call. At Penn, the cardiac surgeons take the donor call. And that probably varies greatly from place to place. And the other thing, I loved, doing teaching and stuff. So I wanted to be an associate program director. And so that was something else I, had wanted to do when I got the job. So what I didn't want to do is just come out and just do transplant and VADs. And also what's important, I think, they changed the allocation system in 2018, I think 19, I forget now. It's been a couple, 3 years. And so the VAD, the number of VADs we do has greatly, changed relative to how it was before the allocation system. And so I think that's something you have to be flexible, because no one really knows the future. They could change the allocation system again, and who knows what that's going to do. So I think starting off, I think it's good for everybody to be able to do bread and butter adult cardiac surgery. And I would be, maybe not, I'd be a little bit cautious about taking a job simply focused on, some niche, so to speak.
Mm-hmm.
I totally agree. And I think 150 is the magic number. That's what everyone says. That's what I put in my contract too. I need to have 150 regular pump cases. Plus I want to do the transplants with my transplant partners. So I think especially as a junior surgeon, when you're coming out of training, it's one thing when you're 10 years in and you can say, I'm going to do heart transplants and LVADs, and I'm going to also focus on kind of administrative work and growing the program, et cetera. But when you're coming right out of training in your first kind of, I would say 1 to 3 years, having the experience of doing a wide breadth of adult cardiac surgery in addition to what your specific subspecialty focus in is incredibly important. So looking for that as you're looking for jobs is important. What was your other part of your question? Now I forget.
Oh, like, are there other conditions that you can look for in your first job that help you get acclimated to this practice? So I talked a little bit about donor call arrangements and maybe even speak about the relationships or the presence of heart failure specialists at your institution, and if there's cultural differences that you even look for in your first job.
I think so for us, I guess donor call, we take donor call as well. The cardiac surgeons take the donor call. So that can be exhausting. We have a super fellow right now that really helps us out a lot with donor call. So he's able to screen out a lot of the ones that we would screen out anyway. So it saves a lot of middle of the night phone calls, which is incredibly nice. But at MGH cardiology took donor call. Here at Wisconsin cardiac surgery takes donor call. So it's just a matter of the way that it's set up at your place. I think especially because of the true multidisciplinary nature of heart transplant and MCS, having a good relationship with the heart failure cardiologist is incredibly important. Trusting them and being able to work as a team, right? They offer a lot to us. They're able to manage these really critically ill patients. They're able to help you think through complicated bridging strategies, et cetera. So when you're looking to join a group, having a strong heart failure cardiology team, I think is incredibly important, because they'll support you just as much as you support them as the surgeon on the team.
Yeah. And that actually reminds me of another question that I've been meaning to ask. Treating heart failure patients, the LVAD patients, probably comes with some additional responsibilities when it comes to their preoperative workup, but also their postoperative follow-up and et cetera. I don't know the logistical details of what that looks like, but can you comment a little bit about how that affects your practice? Of course, the considerations that go into, VAD candidacy or heart transplant candidacy come with different types of meetings and working in different types of administrative settings. And the long-term follow-up, I feel like the heart failure surgeons are more intimately involved in how patients on LVADs do, and you often end up encountering them a lot more often down the road. So how does your day look like with those things in the picture as well?
I've been at I've trained, I've been at Penn, I was at Columbia, I was in Boston. So I've seen 3 different models, and it really depends on where you are. Like, some people do a very strict multidisciplinary approach where a surgeon, an intensivist, and the heart failure cardiologist have to round on everybody, on all the VADs and transplants and ECMO patients, every morning. And other places are more like, okay, you're going to do your independent rounds, and maybe you're going to communicate with each other, and maybe you're not. But I mean, I just, from my day-to-day standpoint, I come in and I walk through the unit. I think probably most people do, but I think you have to pay attention, and, depending on who's in the unit and who's on the heart failure team. And, we're never off service as surgeons, but, depending on where you go, the cardiologist might be on service for a week, and then you don't see them again for a couple, 3 months. Same with the intensive care doctors. So, that you're always with surgery, you're going to be the continuity of care. So I think, and especially for heart failure and transplant patients, like, I'm not micromanaging the immunosuppression, but, volume status, basic stuff like anticoagulation and when to take tubes out, like, you really have to be, I think, really closely following that kind of stuff along. It's not like you do an AVR and then it's pathway. There is rarely a pathway patient. They're all so unique, and they're all often so sick, and you get a lot of experience very quickly. And I think as a heart failure transplant surgeon, you really have to be a good clinician, rounding clinician as well. And again, depending on what kind of practice you join, you'll have a different degree of of interaction with the other teams and a different amount of cohesiveness with the other teams.
Yeah, absolutely. So I've seen now two different systems, the MGH system and the Wisconsin system. They're somewhat similar in the sense that we truly do a collaborative multidisciplinary rounds every morning. So that was something that we didn't start with when I was at Wisconsin, but we've evolved into. And we do that on the ICU patients every day for the heart failure transplant patients. So that involves the ICU team, the heart failure cardiologist who's on for the week, and then the heart transplant surgeon who's on for the week. So we share our patients. That said, obviously, if I do a transplant on someone, I follow that patient really closely. But for the purpose of ICU management, we do function as a team, which I think lends itself a bit better to work-life balance when you share, when you're able to share the patients. And part of that may be that it's myself effectively and one other transplant surgeon, and we work incredibly closely together. And it's a smaller group. I would imagine we're a smaller group than what you guys have at Penn. But as a result, we share things in that way, which is nice, and it's collaborative, and I like that. For the patients that are not in the ICU, on Mondays, we kind of run through the list all together to see if there's any surgical needs, if they've been missed around on the patients, et cetera. So we truly function like as a unit. And what that means too is that you ask what our day-to-day looks like. It's filled with meetings. So there's a lot of multidisciplinary meetings that go on when we're not operating. So we have, for us, we'll do multidisciplinary LVAD meetings once a week. We have our transplant selection meeting once a week. We have some quality improvement meetings that happen kind of bi-monthly. And so there is a lot of collaborative work and interfacing with the other members of the transplant team here.
Yeah. And you mentioned a little bit about work-life balance, which is an interesting subject for heart failure, I feel, because I've heard advice in both directions. On the one hand, you can imagine that the patients are so sick that, it is prone to having more complications and et cetera. So you do have to be more continually involved. And at the same time, like you just mentioned, Dr. Fiedler, there are some aspects of the field that lend itself to a nicer work-life balance because it is very multidisciplinary in nature. And there are transplants and VADs that happen, but you're not bursting with those types of volumes at all institutions, and you split the call responsibilities with your partners. So can you tell us a little bit about what that work-life balance of your job looks like?
Yeah, I mean, I think it depends on week to week and day to day. You just don't know. Like some weeks will be, quieter than others. I think one thing that's nice about transplant is in some ways you do have flexibility. Like if you're up all night doing a transplant and then you don't have a case the next day, you can just go home. And it's great because I have a couple kids and I can put them on the bus and I can take them off the bus. And like typically if I had a regular job, perhaps I wouldn't be able to just take the day off. But when you're operating all night, I think generally people, don't expect you to stay at work the next day. So there's some flexibility, and I find that useful. Yeah, I don't know, work-life balance. It's probably a tough thing. I don't know if anyone's figured it out.
You have kids. It's harder for you than it is for me with 2 dogs. But but no, I totally agree. I think that one of the nice things is just that. I mean, if you're operating all night, no one's expecting you to be, on Zoom from 9 a.m. till 5 p.m. Recognizing that you're tired, and usually the ICU and stuff will try to leave you alone, recognizing that you're sleeping and stuff. So I think that's nice. At the same time, though, we do a lot more stuff in the middle of the night and off hours and weekends than someone who's doing minimally invasive mitral valve surgery does. And so for every day you get to lay on the couch with the dogs watching TV because you did a transplant overnight, you've got 5 weekends that you've missed all the plans that you wanted to do because you're transplanting or you're putting someone on ECMO. But you have to choose the field because you love doing the stuff, right? So I wouldn't want to do minimally invasive mitrals and have every weekend to go travel up north Wisconsin. I mean, I love doing transplants and and grabbing a DCD donor like unexpectedly and things like that. That kind of gets me going. And for me, being happy at work as a result of being really happy because I'm passionate about what I'm doing translates into me being happier than when I'm not at work because I'm not constantly complaining about it and I'm able to have a balance. So,
yeah.
I think that's the thing about one last thing is you have to love transplant. You're a transplanter, you're not a transplanter. And I think even in general surgery no one does general surgery anymore. Maybe people do general surgery, but it was the same thing. It was either you liked cancer operations or you like non-cancer operations. And that was a big division in general surgery. And then I think even within cardiac, then you say, I either love transplant or I'm not a transplanter. And I think that's a big division and you know it if you love transplant.
Yeah. At this point, we're about 45 minutes in, so I just want to remind the people in the audience that if you have any last minute questions, then to post it here. I'll make sure to bring it in before we close up. I did want to talk about research a little bit more because I think a lot of the students who are going to be listening to this, either here or on YouTube or on a podcast, are going to have initially an academic focus or an interest and view MCS and heart transplant as an area with a burgeoning research component to it. So you mentioned a little bit about DCD transplantation. I know that's a topic that's becoming increasingly popularized, even in the United States. Can you guys talk about what kind of research opportunities you have come across and how you see that developing further? There's a lot of different devices that are going to be on the market down the road. I'm sure there will be ongoing clinical trials with different iterations of devices and so on. So maybe you get to hear about the things that are on the horizon that other people on this call may not have heard of. So would you mind sharing some of them? Dr. Fiedler, maybe this one, we'll start with you.
Sure. So I think there's a number of different ways to get involved with research, right? So Marisa and I were in Fred's lab. Fred was an R01 funded surgeon, and we were effectively putting these ventricular restraint devices on sheep. So we were doing open hearts. I mean, I'll never forget. It was just epic. But we're doing that stuff on sheep, which was super fun as a trainee. It was very instructive and I think really helped me get into heart failure surgery. But that clearly kind of R01 funded NIH research is definitely not for everyone, right? And it's exceptionally challenging to do as a surgeon. Not that it can't be done because there's a handful of cardiac surgeons that can do it, but that really needs to be your thing. So I think excluding that, there's a number of ways that you can remain involved in research as a clinically busy cardiac surgeon. And the way that I see those are kind of being a trialist, so getting involved in a lot of the clinical trials, specifically with these device companies and things, which are exciting because you're on the cutting edge. You're doing things that other people aren't doing. Getting a great database manager and biostatistician, plus minus some really good fellows, residents, medical students to help you mine big data sets to do retrospective data analysis on things that can help us move the field forward, or some aspect of translational research, which you can partner with a basic scientist and maybe provide samples or tissue samples, and they can kind of do the heavy labor in terms of the bench work, and then you can write a translational paper. So speaking from my own experience, I was certainly never going to be Fred Chen and get an NIH R01. And so short of that, I've taken the path of being interested in using the databases to explore options for expanded donor criteria, getting involved in some of the clinical trials, specifically with, Medtronic and Abbott. Momentum, obviously everyone's involved with that, but now they're opening the SWIFT trial from Abbott for the HeartMate 3 via bithoracotomy approach, which I think will be fun. Lateral trial with Medtronic. These are all areas that as a surgeon, you can contribute patients and expertise without having to be too bogged down in the day-to-day research. There's also a lot of opportunities for residents, fellows, and junior faculty members to explore funding opportunities through TSF, AATS. So I was lucky enough to just win a AATS grant looking at proteomics in DCD heart transplant. And that again is in conjunction with a basic scientist. So we put together a collaborative research plan where I'll give her tissue samples and we'll look at echo and as well as the proteomics for these DCD hearts. But none of this research is taking away from my day-to-day clinical responsibilities, right? So me personally, my objective is to be a busy clinical cardiac surgeon, transplant transplant surgeon and also contribute to the field through academics and research. And so this is how I've chosen to explore it. I think it's also really a fun way, research in particular, to get the medical students and the junior residents interested in and excited about our field. So that's something that I've really enjoyed as a junior faculty member, just kind of like letting medical students write some case reports or get involved in stuff. And then you take them to the OR and then all of a sudden, you know, they wanted to be a pediatrician and now they want to be a cardiac surgeon. So there's nothing better than that. So staying involved in research, I think, is important. And I would encourage you all to, when you're looking at jobs, choose an institution that'll give you the support to do that.
Yeah, that's really helpful. No, we're sort of coming up at the end of the hour at this point. And, you know, as a trainee, I look at this field as an incredibly exciting opportunity for a lot of people who are interested in heart surgery in this day and age. And so I'm really excited to be able to have this conversation with you guys and give, you know, trainees and students a closer look at what it is like to be a successful early career heart transplant and MTS surgeon. But, you know, if there's any last words that you may want to say to our audience, maybe, you know, it doesn't even have to be technical advice, but just something that you kind of want to leave them with an impression of your career and your path here, that'd be greatly appreciated. I don't want to really put anyone on the spot because it may take a couple seconds to think of.
No, you'll always have a job. People want transplant surgeons. That's, you know, it's never going to go away either. So I feel like you do transplant, you have good job security. These patients are hard to take care of. And so it requires dedication. And if you can do it well, you will always, you know, have a job. So I think, you know, it's a tough life, and but it's extremely rewarding. There's really nothing better than transplant, and you will be in demand.
Yeah, so job security is incredibly important. I would argue that. I would say that as well. But I do think it's an exciting field and it's constantly changing. And that's something that I really appreciate about it. It's big open surgery. It's thought-provoking. It's multidisciplinary. And it's just a lot of fun. It's incredibly rewarding, like Marisa said. So for me, I'm comfortable giving up some of the nights and weekends for the opportunity and kind of the privilege to do what we do. And if you're at all interested in the field, I mean, I'm sure that Marisa is okay with this too. You guys should reach out to us. Jason can provide some contact information. But for people like us, it's really fun to get other people excited about what we do, because like we've said throughout this hour, we do it because we absolutely love it. It's not because we couldn't figure out something else that we would want to do. You know, I always joke that I would be a real estate agent if I wasn't doing this, but I just, even with the bad days, I never want to give it up because it's so fun and it's so rewarding. So excited that you guys are all interested in exploring our subspecialty.
Yeah, and I'm really glad that you became a transplant surgeon instead of real estate. But thank you so much for giving us your time this evening. I know that it's a Thursday evening and we're heading into a long weekend. But I think this is a really valuable conversation to be had for all of our students and residents who may listen in, not just today, but down the road as well. So I really want to thank you again, not just for myself, but also on behalf of the TSRA. So I hope everyone had an educational experience, and then we look forward to having you again for some other conversations in the future. So thank you so much.
Thanks, Jason.
Hi, Amy, great to talk to you.
Good to see you too.
Good catch-up opportunity.
Bye, guys.
Bye-bye.